Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And this evening I have the opportunity to talk with Dr. Alan Roth and Dr. Michael Fine and Ms. Shannon Brownlee. And I will introduce each here as we go. First, Dr. Alan Roth is Chair of Family Medicine and Palliative Care at Jamaica Hospital in Queens. Thanks for joining with us, Alan.
Thanks for having me, Larry.
Dr. Michael Fine is Chief Health Strategist for the City of Central Falls, Rhode Island, and he was formerly Director of Rhode Island's Department of Health. Dr. Fine, thanks for joining.
Great to be with you, Larry.
And Shannon Brownlee, who is a Senior Vice President for the Lown Institute in Boston. Shannon, thank you for joining with us.
My pleasure.
And I'm going to turn things over to you, Shannon, to start our conversation.
Great. So I'm glad to be here with Alan and Michael, old friends and two people I know who have gone through some pretty remarkable times dealing with the COVID outbreak in their respective cities. And Alan, I want to start with you. I know that we were in contact at different points during the worst of the sort of apocalypse that hit some of the hospitals in the New York City area. Can you tell us a little bit about kind of what did you expect leading up to the peak of infection at your hospital? But actually, first, tell us a little bit about your hospital and your role at the hospital.
So Shannon, you described it well as an apocalypse. I'm chief of family medicine in a small urban community hospital, part of a two-hospital system in a very underserved part of Queens County that serves a very diversified population. Queens County is the most culturally diverse and most underserved of the 3,000 counties in our country. We're a hospital that relies on mostly public funding, about 60% Medicaid, 20% Medicare, and 20% everything else, including uninsured. So we take care of a really, wonderful group of diverse people who have immigrated to this country. And, what I saw and what I was prepared for is nothing that my 35 years of medicine training and education could have ever prepared me for. It was an apocalypse, like you said. Nothing like I ever thought would happen in the United States. Like a wave hit us. Like, one day we heard that, COVID was in the United States. And I remember March 1st hearing it was our first patient in the hospital. And, 2 weeks later, the hospital and the county was, overrun with very sick COVID patients. And we prepared ourselves, and I was part of a COVID task force and the clinical lead task force. But we heard the governor and the president talk about ventilators and needs for beds and stuff, and we did all that. But it was a very surreal type of experience that growing up in the AIDS epidemic as a young doctor. This was just very unique and different.
Wow, it sounds like it. Tell us a little bit in terms of specifics about what the hospital did in terms of getting prepared.
So we got a directive from the state of New York that we needed to double our bed capacity and double our ICU capacity almost immediately. Like there was timelines, like by the next week. So we literally walked from floor to floor and said, what can we cover? What can we close? Excuse me. So we closed peds and sent them to another hospital. We closed our psych units and sent them to another hospital. We closed our OBGYN and sent it to another hospital. And essentially in the matter of a couple of weeks became a COVID hospital and COVID ICU.
Wow. And how are you supposed to do that? How are you supposed to increase your capacity? How are you supposed to increase your ICU capacity, provide that much so quickly? What do you have to do?
Well, I'm sure everybody heard you needed ventilators, and fortunately for us, we did get the ventilators, and we never ran short. But we just needed to make it happen, and we turned psych beds into medical beds, and OBGYN beds into medical beds, and peds beds into medical beds, and surgery was closed. The whole hospital closed except for the emergency department. Our ambulatory care network scaled down 80%, and all of our AmCare doctors were brought inpatient. Our pediatricians became adult providers. Our OBGYNs helped us out as adult providers. And people like psych and podiatry and dental interns became, medical interns overnight. It just happened.
Wow. Wow. So, Michael, I want to kind of turn to you for a moment and kind of stick with this conversation about preparedness or getting ready for the onslaught. What was it like for you in Rhode Island in terms of what was your role and what did you do in terms of getting ready for COVID?
Well, I had a couple of different roles, and they overlapped and then diverged. First, I was and still am, the chief medical strategist, the healthcare advisor to actually two mayors in Central Falls and in Pawtucket. I worked part-time for a community health center, and I also had started being a video commentator on a video website, and did a daily, basically, interview on the COVID-19 situation in the United States and around the world. So I was looking every day at the numbers, starting in the beginning. I should tell you a little bit about Central Falls, because it's probably, in some ways, it's got some similarities to Queens. It's the poorest and smallest city in the state of Rhode Island. It's 1.3 square miles, 20,000 people, 70% Latino, many people living in poverty, many undocumented immigrants. We don't know exactly how many, but most of us think about 5,000. Many people without private transportation, and very densely packed. Traditionally, the most densely populated city in the state, and I think the 25th most densely populated place in the United States. So it is people jammed together. So in those roles, one role, as I said, was being a commentator and checking, looking at what was happening around the world and around the country as the pandemic moved closer. One role was advising two mayors about the preparations that needed to be made and what this thing was about anyway, and what the cities ought to be doing. And one role was in a community health center, which itself had to prepare and then totally change what it did in terms of patient care over a couple of weeks.
Wow. So similar sort of, got to get things going really fast for a population that is probably going to be pretty hard hit. I'm going to turn back to Alan now. So your first COVID patient was March 1st. And can you tell us a little bit about that patient and what sort of, how involved you were in that patient's care?
So that was our hospital's first COVID patient when I first learned about it. My personal first COVID patient was unfortunately about 5 days later, and it was unfortunately one of our family medicine residents who was rotating with me in our family medicine practice, and I started questioning him about his respiratory symptoms and what was going on, and found out very quickly after I asked him, I said, "You were on your peds rotation last, right? Is that why you're so sick?" And he's like, "No, I was traveling." And I was like, "Did you hear about the COVID yet?" And he actually hadn't even heard about it. We were in the first week of March, and being in the country. And he gave me the gift of COVID, but before giving it to me, he ended up as my first COVID hospital admission, and almost lost his life. He developed COVID pneumonia, was hospitalized for about a week, and was literally out on leave because he couldn't stop coughing for about 6 weeks. So he missed about half the COVID epidemic, and was the first of probably 2/3 of our residency program and more than half of our faculty that got infected, myself included. And like I said, it was an apocalypse. It was a tsunami that came in that we just didn't know. It came so fast, a matter of days. And we just, we didn't know what was hitting us until we were deeply enmeshed in this. It was unbelievable.
Can you give some numbers to what being part of a wave was? I mean, how many patients were coming in a day, and how many were you ending up having to hospitalize?
So very quickly, the hospital emptied out, and Michael, who's a good friend of mine, made me laugh because Queens County has 2.3 to 2.4 million people and between 200,000 and 400,000 undocumented people in the borough. And I thought every one of them was my patient in the last 3 months. That's what it felt like. It's been the longest 3 months of my life. And it was just almost overnight, our hospital closed and became a COVID hospital. At times, there was close to 300 COVID patients in our institution, with half of them on ventilators. It was an amazing number. Early on in the epidemic, we were told, don't use things like BiPAP and high flow. If they get sick, intubate people. And that's what we were doing. And every day we got a different directive. And then it changed, don't intubate people, give high flow and give BiPAP. And, in the beginning, it was, save your own life. And then it was, save the patient's life. And then there was a combination thereof. But we became overwhelmed really, really quickly. And, I think we as a team in the hospital did such an amazing job coming together, creating multiple COVID services that worked as COVID teams. Because that's all we had. Everything else closed down.
Michael, when did you know you had COVID on your hands?
We had the first case in one of the cities that I work with in the 3rd week of February. Travelers who had come back from Italy who became symptomatic and positive. And that got me paying even more attention than I was paying already. And then we had a pretty long lull of not much happening. And actually, what happened pretty quickly after that was the outpatient volume disappeared, sort of like a wave that was going out. And we actually didn't have much to do. Very the opposite experience from Alan's. And during that period, I was working with the mayors and talking to the school systems and talking to the city councils and helping people understand what was going on. And one of the first things I said to the mayors was, we need to get set up to do some testing. And we're going to have some challenges because the state's approach to testing and to other things depended on having people call their primary care doctors. And because of some other work I had done at the Graham Center, I knew that likely 50,000 people in both cities had no primary care doctors. So there was no way for them to get a test. And that started a months-long battle with state government to get resources into these 2 cities so that these most vulnerable people could be best protected. And that was a sort of daily battle, but all that changed when someplace toward the end of March, I believe, we had our first death in a house. And we would then, in short succession, hear about 11 deaths between the two cities of people who had died at home, very likely from COVID, because they didn't have access to care. So that's how we knew this was a real thing. And then we started hearing about people in their apartments where there would be 6, 8, 10, 12 people all sick at the same time. And that's when we started to see the testing started late. And when it started, we began to see the numbers climb quickly, so that today we're probably in the top 10 most infected places in the United States, just a little behind Chelsea, Massachusetts, with a case infection rate that's higher even than Queens, higher than New York City as a whole, and higher than the Bronx.
So when you say case infection rate, you mean a population infection rate for a particular area? The number of people, the prevalence of infection?
The prevalence of tested positive cases. Remember, tested positive cases doesn't necessarily mean the prevalence of the disease, which is likely much greater. But just of tested positive cases, again, quite high indeed.
Wow. So Alan, just to continue the part of the conversation we were having, you were saying that it was just an absolute tidal wave of patients. How long did the tidal wave last?
So it lasted until a couple of weeks ago, but what struck me, what Michael just said, the vacuum of primary care that happened almost overnight. So I'm in charge of running 10 inner city ambulatory care clinics and several faculty practices. And almost overnight, they disappeared, like no one was there, and the people were scared to come in. And to me, probably one of the greatest mistakes that the system made during this time was telling people, don't come out, stay home, don't seek medical care. And, we as a system did similar things and thought people were okay at home and they were safer there. But we learned in retrospect, like Michael said, that people were at home dying because they were scared to come in and get health care. They didn't have access to pulse oxes. They didn't have access to someone to listen to their lungs. So they stayed home with a horrific respiratory infection that we're telling people don't come in unless you really have to. And the only way we really knew is if one of us listened to their lungs and looked at them and checked their vital signs and did a pulse ox, because one minute these people were okay and the next minute they were coding. And so many people died at home because we told them to stay home.
And wasn't this one of the sort of tricky parts of this disease, that people would come in and they would not be in respiratory distress, but their pulse ox would be so low, you'd think, why are you standing up? And so I can imagine that happening to people at home where they don't necessarily feel like they're having trouble, but they really are already in trouble.
And we, unfortunately, Shannon, we didn't learn it until it was too late, until we lost people, because we were told it was too great a risk to the greater good to have people come in that were sick and stay home. And staying home without having proper monitoring, proper lung exam, pulse oximetry was unfortunately a death sentence to many people in the community.
Yeah. We read in the paper, in the New York Times, including the New York Times, which was reporting on Queens and Brooklyn and Manhattan and the other boroughs, that hospitals were having to have, refrigerated trucks to be able to handle all the bodies of people who were dying. Did you see this at your hospital? Was it that overwhelming?
So unfortunately, we had to close the street behind our hospital and build makeshift ramps, and we had 4 tractor trailers of trucks at our hospital. 4. Wow. This is not normal time.
this is not normal for a hospital in Queens.
Not normal for the United States of America. It never should have happened.
Did
Can I
you
interrupt
lose?
here? Can I
Yes,
interrupt and
please.
ask Alan? Alan, describe what the emergency room was like.
It was just overrun with people. It was, we couldn't close our doors. We had to assume that everyone that came in had COVID, and there were, multiple people intubated on vents in an emergency room that was overwhelmed. Our hospital was not one of the ones on TV. Elmhurst is the classic one that you saw that, multiple people or hundreds of people. And that's what it was like in multiple hospitals throughout New York City. It was overwhelmed in a matter of days.
Did you have enough personal protective equipment for medical personnel and for anybody who had any contact with patients?
So, we certainly got scared early on and what we heard that things were going to run out. Fortunately, it never happened. Some of the equipment that we got coming in later on was, not the, the 3M quality kinds of stuff, but, I never had to use a garbage bag or anything like that, I saw on newspaper and TV things. That never happened to us. Our hospital did do the best to protect, the employees, yet, many of us got sick, and, it was just so overwhelming. We never got the need to, say who's going on a ventilator and who did not, but, we didn't have the ability to put, 300 people in an ICU. And I could tell you that, if you're a COVID patient and you're getting admitted to the hospital, by definition, you need ICU level of care, because that's how quickly people go down.
Wow. So if you were sick enough to be in the hospital, you were sick enough to be in an ICU.
Correct.
Did you lose any employees, any hospital employees to COVID?
Unfortunately, we lost one of the most beloved doctors in our hospital. We've lost paramedics and nurses. There's been several. But one of our chiefs of psychiatry, who I've been sharing pictures with, Larry, who's been sending wonderful gifts of candy to us, is about to get discharged in a couple of days after being on a vent for almost 40 days, and is about to go home. So we have the wonderful stories, and we unfortunately do have the stories of the people we lost.
Mm-hmm. How is the hospital, and how are all of you who work there dealing with all of this, the sort of emotional fallout? I mean, that's an enormous toll, not only what you went through, but losing colleagues and friends. And now, are you supposed to just pick up the pieces and go back to taking care of people with lacerations?
Honestly, very few of them are coming to the hospital. We normally get about 350 ER visits a day. We're getting about 100. I don't know where the heart attacks and the strokes went. I know a lot of them died at home that shouldn't have. I know people are scared to come to a hospital in New York because we're seeing it all day, and people are scared to come to our offices and would rather be home sick. And it's unfortunate because it's very slowly coming back. And I'm hoping we get our people in for the care before, what many of us expect will be a second wave. But I do think our hospital has done a good job of, wellness programs, doing the best to have our mental health providers, have, virtual office hours and in-person office hours for the staff. But, I think many people will not be the same. You know, when you see hundreds of people die in a very short period of time, when you see the pictures of the refrigerated trucks and you're standing next to them, what you saw on TV, and, you know, bodies are being wheeled in, it's, like I said, I grew up in the AIDS epidemic. You know, Michael's 1 year older than me, saw this too, and it's just different now. It's like, you know, it's 35 years later. We should have been prepared for this as a healthcare system, and we were not. And the have-nots, like the place that I work at, you know, in a very small, underserved system, you know, we didn't have the Army, the Navy, the Air Force, and Marines alive like many other hospitals did. Yes, we got patients to the Javits Center and the USS Comfort and all that, but it was a joke, you know, the kind of patients they took. You know, they took people that were healthier than I am right now and didn't want to take the sickest people.
So you were taking care of all those super sick people in what amounted to a hospital-wide ICU.
Correct.
And is the hospital? I mean, I'll ask the question again. I'm sorry if I'm pushing on you, but is there any kind of effort, or are you organizing any kind of effort for, say, your residents to kind of deal with this? This is, you know, there must be a lot of grieving.
There is, and everybody, as you know, Shannon, deals with this different ways. So, you know, I just organized this week. Some of us know Jeff Geller is going to be doing empowerment, virtual group visits for our residents. We have psychiatrists, we have therapists, we have our Department of Family Medicine and other departments. We have our CIR union for the residents. Our residents are unionized, and we have things for the faculty. So there's a lot going on. You know, we're doing what's called virtual Schwartz rounds right now. Like, there's a million things happening, but, you know, everybody deals with grief in a different way, including myself. You know, I bury myself deeper in my work and, you know, try and say, like, what am I going to make good happen out of the crap that we just saw? And, you know, that's how I deal with it every day. And everybody's different, but, you know, I think our institution is doing the best we can. I wouldn't be surprised if, you know, some of our residents, you know, change careers. I wouldn't be surprised if some of the students that were there early changed careers. I just don't see medicine being the same as it is. And, you know, I think the damage is going to take years for us to assess the damage that has happened to our healthcare system and our young trainees, and how many older doctors that are going to say, I'm just not going to do this anymore.
That would be a tragedy, wouldn't it? But it's not surprising. Michael, hearing what Alan has been talking about, where do you see parallels in what you're seeing in Rhode Island? I mean, it sounds like Rhode Island is still very much in the midst of the infection.
We are. The things are beginning to wane now a little bit. You know, we didn't have anywhere near the intensity that they had in New York, or anything like what Alan managed to survive. You know, we managed to get to social distancing early enough so that the hospital load was controllable, and, you know, we didn't overwhelm our capacity. And we're a smaller place to begin with, so that was a good thing. But what we saw was a really painful social abandonment, which had a different character. So when we went to a shutdown and a stay-at-home order, they let businesses and factories stay open, mostly factories stay open, without really thinking what that meant. And what that meant was that people who were undocumented, or people who were working people and had to work every day, they couldn't work from home. And they couldn't imagine themselves as being able to afford not going to work. So they went out to work every day. They'd get up at 5 in the morning to meet little minibuses that leave and go to factories all around New England. And in the minibuses, the disease passed from person to person. And in the factories, the disease passed from person to person. And then those minibuses came home, and people went into apartments that had 6, 8, 10, 12 people, and entire apartments got infected. And that was a kind of cynical social abandonment like I've never seen. It was, sort of this institutional blindness that we could just keep factories open to preserve the economy and not think much about what was going to happen to the people who worked in that economy. When there was, early on, the Department of Health managed to get some respiratory clinics open, places people could go if they were coughing or febrile to be looked at, and had enough personal protective equipment, or were opened in our richest community at a time when there was none open in Providence, Pawtucket, and Central Falls. It took weeks of begging, basically, to get any kind of testing open in Pawtucket and Central Falls, as if this population of people just didn't matter. And watching that happen and watching the people in these communities feel abandoned, it was something I'll never forget. Now, the good news is we were able to get both cities to join together, stand up an incident command system when we realized that the cavalry we were begging for wasn't coming. And we put something together on our own that's actually quite amazing. We now have an 800 number for people to call, whether they have a primary care doctor or not. And as soon as we ask people to call us, as soon as they get a symptom, and we often now are getting calls the same morning as somebody wakes with a symptom, we can get them tested in a couple of hours, but more important than the testing, we get them into isolation right away, even before a test. We've got and we have a number of volunteer clinicians who take their calls and help sort out whether they sound like they're safe at home, whether they need the hospital, and help walk them through what it's like to be in isolation and to protect their families. That's been an amazing process to put together. And then we also were able to put together a whole family support unit so that everybody in isolation gets called a couple of times during their isolation. They get food, they get emotional support, they get disinfectant and masks, and undocumented people get some cash so they can survive the isolation. Seeing that come together was an amazing thing, but it came on the heels of this sense of these communities just didn't count for anything. And that's a piece that I'll never forget.
Michael, I want you to learn from I want Michael to learn from my mistakes and bring those people in and put the stethoscope on their chest and get a pulse ox on these people before they're dead, because I lost more people than I ever want to lose in my career from being told by our government to tell people to stay home.
Right. Well, the problem that we face, Alan, the very difficult problem, is we don't have any place for them to go. We don't, the major community health center did not open itself to new patients. So it was willing to care only for its own patients. And our only option for this whole 50,000 person group of people is to be in touch with them by phone regularly, not abandon them, but be able to tell them, the moment you get something that feels like trouble, call 911 and go to the hospital. And having us say that, we think has had some pretty good effect. It's not anywhere near as good as putting a stethoscope on somebody's chest, but it's really the only option we have for those people.
And when you say you didn't have any place for them to be isolated, so, in the past, in epidemics, there have been isolation hospitals or places where people who were infected could go and be away from their families, be away from other people who weren't infected until they were no longer infectious. And so when you say we put people in isolation, what did that actually mean?
That's isolation at home, because I've spent the last 2 months using every public opportunity available to me to say we need medical isolation in each community that's culturally appropriate, that's language sensitive, and it hasn't happened yet, Shannon. There is, we can, if we're lucky, we can get people to a hotel 15 miles away where there are no speakers of Spanish or no speakers of Creole, which is a major language in these two cities. So, it was not a place the state government was going to go. I'm still hoping that the cities will be able to figure out a way to get it done locally, but it really needs to happen. And that wasn't part of anybody's planning, despite a number of people saying pretty clearly and loudly that that was going to be necessary if we were going to stop disease transmission. That has been a major focus of lots of our advocacy, but it hasn't yielded positive results yet. So to your question, what we coach people to do is to find a room, to go into that room and stay there by themselves for 10 days, to wear a mask while they're in the room. We coach people through, making sure they get their meals delivered in front of their door on a paper plate and have the deliverer go away so they don't, so there isn't respiratory spread. We coach people about if, often there are many people using a single bathroom. So when the person who's ill uses the bathroom, we coach them to wash it down with disinfectant as soon as they're done and get the next person to use it, to wash it down a second time before they use it, to make sure people don't go into the living room or dining room or den. This is second-rate isolation on a good day. And I can't tell you how well it's working. I can just tell you that's all we've got.
Yes, it is all we've got. And that, I think, kind of helps us go into the final part of what we want to talk about, which is lessons learned. And Alan, you gave us one lesson that I think is really important, which is that it was a mistake to say, stay away from the doctor, stay away from the emergency room. How would you have worded that differently? Because on the one hand, you don't want people with, minor problems coming in and potentially getting infected with COVID. On the other hand, you do want people who are seriously ill to seek the care that they need. So how could that needle have been threaded?
It's a tough question, Shannon. I've taken care of people in the E-train in the subway below our hospital, and the president of the borough is my patient. So that's the diversity of my population that I take care of. And, we needed to see people. So we needed to get to people's homes. We needed to get NPs to people's homes. We needed to get PA to people's homes. We needed to put a pulse ox on people, because this is a disease that if we're going to prepare for the next wave, and I actually had a meeting today in my hospital, and they said, what's the most important thing to prepare for the next wave? And I said, we need more ICU beds. We need more beds with a monitor, and we need pulse oxes and people to watch. But it's not a complicated disease. It's really not. And unfortunately, I've been in Remdesivir trials. I've been in hydroxychloroquine trials. We've had multiple trials in our hospital. For a community hospital, we've been in every trial. Haven't seen anything work but intensive symptomatic management and respiratory support, and that includes non-invasive ventilation until you have no choice. And we couldn't do that in people's homes. And we need to prepare for the next wave by having monitors for people, especially in people's homes. We need people to be able to evaluate people in people's homes. And we need a capacity in hospitals that has not double or triple, but quadruple the number of monitored beds where someone is looking at someone's vital signs, including listening to their lungs and their pulse oximetry, because that's what made the difference in this disease.
And a monitored bed isn't just having the equipment, it's also having the personnel.
Correct.
So you're saying that hospitals need to be ready for this second wave by increasing their capacity, not just in terms of the equipment, but also in terms of the labor. And where do you get that labor? I mean, I can see getting more ventilators in, but where can you get that labor?
Fortunately, we didn't need the ventilators, but we needed people to make sure these people weren't crashing in respiratory distress, and knowing who could stay on high flow oxygen, who could be on BiPAP, who could be on regular oxygen, and who unfortunately only hope for survival was to be intubated and mechanically ventilated. And we're not there. We're not there as a system in New York, and I'm sure not in this country.
Do you think that hospitals? Yes, Larry.
No, this is Michael.
Oh, sorry, Michael.
Because I was studying the outbreak, I knew something that not everybody knows, which is in Wuhan, when they went to finally got around to stopping the outbreak in Wuhan, they brought in 42,000 healthcare workers from around China, and that's what helped them attend to it. We needed to bring, 42,000 or more health workers from around the nation to come and help in New York. And we just don't have that kind of system, organization, or design that lets us do that. So we can talk about the need for extra workforce. But it's not just workforce, it's organization and deployment and logistics. It's being a system instead of chaos.
Well, you anticipated my next question, which was, how do we set things up so that you can have the kind of personnel that you need in hotspots when you need it? And that, as you say, requires a system where you have housing for people, you have the equipment that they need, the personal protective equipment that they need, they have a place to live, they can come in from other parts of the country when they're needed, and then they can disperse when they're no longer needed, having been tested, of course. We don't have a system, and that's, I think, one of the biggest lessons that we should be taking away from this outbreak. There are public health lessons we should be taking away as well, aren't there? I mean, Michael, you talked about isolation. You talked about bringing food to people. You talked about financial assistance. These all need to be thought of as public health interventions in an outbreak. And we are going to see something. I don't know whether it's a full second wave, whether it's going to be worse, whether it's going to be not so bad. But this infection is not going to go away. And so what are some of the public health measures that need to be set up and could have been set up beforehand, but weren't? But now that we've seen this time, what do we need to do to get ready?
Well, the first thing we need is a good test for asymptomatic disease. We do not have adequate testing, not in terms of numbers. We don't have a gold standard test. So we have no way to know who's a carrier of the disease and who's disseminating it, by and large. That, to me, is a huge disaster. We need, if we're going to do contact tracing, and it's worth doing, but it's very tough to get it happening fast enough. Basically, if you understand the public health piece of this, you have to get to someone's contacts and get them isolated 4 days after the person has the index case has symptoms. Anything after that, you've got generations of transmission, and we're just wasting our time. So we need not just contact tracers, and they're hiring a zillion in New York and another's doing it in Massachusetts. And my guess is it's whistling in the wind, because we don't have the level of organization and logistics we need to really get them doing what they to get them to do what they need to do. You know, we need to be honest about what our testing can and can't do, and we need to be very aggressive about isolation. We need out-of-home isolation for everybody who's sick, and we need to be able to move people there at the development of the first symptom. Remembering, at the development of the first symptom, you know, they're 2 days into having been spreading disease.
And, you know, the hotels are empty at the moment, and the convention centers are empty at the moment. And so it's not like we don't have the space for isolation. What we don't have is the infrastructure.
We don't have the infrastructure, and we don't have the moral courage and commitment. You know, one of the things that a number of us in Rhode Island started to say as soon as this hit is that we need to get everybody who's homeless into a hotel, because there's no way to keep this from spreading in the homeless population. It didn't happen. You know, I mean, we got some people.
And so we got the homeless population being highly infected.
Right. We did that. I mean, just if nothing else, there was a homeless population. You know, that there are 60,000 homeless people in New York City, you know, is crazy. And that's why, you know, we were a setup for this to happen. We were a setup because we didn't really have any focus and leadership around logistics. We didn't have focus and leadership around, you know, the isolation of people who were sick. CDC didn't actually, in my view, tell the truth about what we all know about viruses. You know, their initial presentation, their initial argument was that you only needed to test symptomatic people. That's because asymptomatic people, they said, couldn't spread disease. That was patently false and obviously false to anybody who's got any experience with infectious disease on the front end, but nobody called them on it. You know, and that was taken as gospel, so that we blew our opportunity to contain this disease when it arrived, at least on the East Coast. You know, they actually did a pretty good job on the West Coast, but on the East Coast, we totally made a mess of it, and that's shame on us.
Do you think there's a chance that we can and will get prepared for a next wave?
I would like to think so, but I have not seen us coming together as a nation. I haven't seen the organization of the moonshot to make sure that we have the equipment we need, to make sure that we have the logistics we need, to have figured out how to move workforce around, because the next wave, when it hits, won't hit every place at once. We know that from this one. You know, I haven't seen the nation turn on a dime and develop and put all sorts of energy into developing a gold standard test, which we really need. You know, like, we're just testing a lot of people as if testing makes a difference. And I haven't seen real advocacy for medical isolation in any jurisdiction. And that, you know, that's that absence of leadership. And that absence of
So Michael Talent, I think we are ready for the moonshot. I think we are ready for testing and isolation and contact tracing and putting people in shelters and isolation and all the things we need to do. We are ready. It's not that costly and it's not that dramatic, and we have the ability to do it. We got to want to do it. And I'm not sure we have the want to do it, because I don't think people care about the people that you and I take care of.
Yeah, I don't think anybody's in charge. And I think there are too many people who think they can hide out on a desert island and wait till a vaccine comes, and that it's never going to happen to them.
Yeah. That, you know, those of us who have the luxury of being able to work in our homes and keep our jobs and get our groceries delivered aren't seeing what you guys have seen and aren't concerned about the people who are being hit by this disease. So is there anything either of you would like to say to your fellow family medicine practitioners who may be listening to this about what they may need to do or what you hope for them?
It's Alan. I think we didn't discuss one more thing. It hit me now that I wanted to just get out. The other major mistake we made was that, locking doors on nursing homes and senior places and not letting families visit people is just wrong. I don't know how many people I was involved in the end of their life and how many people died because they didn't have a caregiver that could take care of them, and how many people died alone that shouldn't have died alone, short of, a paper bag, PPE, and a mask. Like, it just shouldn't have been. And that's the thing that's haunting me the most right now. And I think we have to correct that before the next wave. It's like, we can't let this happen again. Like, no one should die alone. It's more than goggles, masks, and a little PPE to let someone die with someone they love. And I can't tell you how many of my patients wouldn't go to the hospital because they were scared to die alone, and how many times I felt the same way. And we need to fix that before the next wave happens, because it's not right, it's not fair, and it's just not necessary in our country. We have the ability to handle it.
Thank you for saying that, Alan. My mother is in exactly that spot. She's 90, she's in assisted living, and she's basically in her room 24/7, and I talk to her and I can hear the mental deterioration that's happening. And she sounds like she's dying of loneliness more than anything.
Shannon, this is not necessary. It's not appropriate. It's not necessary. This is not the 1870s. Like, we need to fix this problem now before the next wave. No human being deserves to die alone, and we're killing people in this country because of it.
I agree. Michael, any last thoughts?
Well, I think my last thought for colleagues is that it's a thought I probably had before, but it's that, we're not going to be able to take care of the things that aren't working by just being in the exam room or just doing telehealth. What are too often called the social determinants of health, that's jargon, but the real thing is, this isn't going to change unless we change it. And, we're not going to be able to function the way we want to function unless we step up a little bit and talk to people in government and talk to people who are patients and help people understand that we're all going to have to take better care of each other if we're going to prevent a virus like this from pulling us apart.
Well, with that, I think we're at the end of our hour. Thank you so much, both of you, for being here. But more than anything, thank you for serving your community in the way that you have. You're heroes, and I know that that's not what you signed up to be, but you are.
Well, thanks,
So thank
Shannon,
you.
thanks for saying that, and thanks for the humanity with which you conducted this interview, which was quite spectacular.
So I'm going to bring things to close. Thank you, Michael. Thank you, Alan. Thank you, Shannon. And we hope that this message, which we'll be sharing broadly, can help others prepare in the way that we're talking about here. So thank you very much.